Hi, welcome to Quality. This is Arjun Venkatesh, your host, where we're exploring quality in emergency care. Today's episode is part of our series for the Emergency Quality Network Substance Use Disorder Initiative. I'm joined by Dr. Scott Weiner from Brigham and Women's Hospital, who is a co-lead of the EQUAL-SUD initiative. And our special guest today is Dr. Alexis LaPietra, who's System Director for Addiction Medicine at RWJ Barnabus Health in New Jersey, and an emergency physician who is remarkably thoughtful, skilled, and known for work around how we can think about pain management, pain control, treating pain in a variety of different ways. Today's podcast is on a really specific aspect of this, which I know many people wrestle with, which is how do you treat pain in patients who have an opioid use disorder? And so we're going to go through some challenging cases today. But before we jump into those cases, Alexis, I want to sort of give you the chance to sort of tell us a little bit about, how you got into this work and how did you sort of find yourself as an ER doc focused in leading an addiction medicine service and really focused in on how we can treat pain.
Thanks, guys. Well, I appreciate you having me here. It's an honor. So at the end of emergency medicine residency, I really wanted to have a little niche. I wanted to feel like I was doing a little bit extra, and I was very interested in pain management. We had an ultrasound guided regional anesthesia lecture by an anesthesiologist when I was a resident. And after that discussion, I went up to her and said, you guys do airway stuff, we do airway stuff. You guys are poking people and blocking people. We should probably poke people and block people. And we realized there's a lot of overlap. So I did a pain management fellowship, focused a lot on regional anesthesia, did a lot with pain management, opioid sparing protocols. And this was all prevention of opioid use disorder because, of course, we've been in this pandemic for so long. But when you stand up and look around, the prevention piece is very important. But the treatment of opioid use disorder is wildly important because there's so many humans who are out there suffering with OUD. They are on our doorstep, they are in our beds, and we are discharging them. And we have Scott, who's published some amazing data on the mortality in this population, which is about 7.5% at 1 year post naloxone. So we know that we have a duty and obligation to treat crises and chronic medical diseases. And this is a chronic medical disease that presents in crisis with overdose typically. And when folks get into treatment for opioid use disorder, we of course have other challenges with managing their pain when they're on medications for that. But it really kind of evolved, just there was a massive gap and no one was really doing it. So I have many mentors to thank for getting me to this space. And it's been a wild ride, but very gratifying.
Great. Well, thank you so much, Alexis, and thank you for being here. And I'm just going to take like a fanboy moment for a second. You are such a hero to me and so many other people. And for those that are listening that are not familiar with Dr. LaPietra's work, she's really brought this concept of alternatives to opioids in the ED all the way up to the federal government to get funding for demonstration projects. It's really incredible work, and we've learned so much from you. So thank you. Thank you for that work. Really appreciate it.
Thank you.
What we thought we'd do with this session is really just focus on some cases that all of us see in the ED, but are really challenging in this era of so many patients with opioid use disorder. And so I think what we'll do is we'll just dive right in and we'll just talk through. We have 4 cases planned that hopefully will be interesting for our learners or for our listeners. And they're all patients that have opioid use disorder, but also have pain. And I think that that's a real challenge, right? Because we're really scared to use opioids in patients with opioid use disorder. There's medications like Suboxone and naltrexone that people are taking currently. And so I think that the first one we'll jump into is, let's just say there's a 28-year-old male who has opioid use disorder. The patient actively uses fentanyl and admits to it, but they're not interested in treatment yet. And unfortunately, the individual suffered a fall and has a bimalleolar ankle fracture. So ortho sees them. They're a candidate for splinting and outpatient follow-up for consideration of surgery. In the ED, we've given them our typical, right? We've given them ibuprofen and acetaminophen, but there's no effect, and he's still in marked pain. What do you do for this patient that's struggling with addiction, actively using fentanyl, so obviously has tolerance, and our usual go-tos are not working?
Great case, Scott. So all of these cases are going to be challenging and somewhat complicated, and that's of course why we're talking about them, because they're cases we will see. And when you're trying to manage this clinically in the middle of a chaotic ER, it's sphincter clenching at best. So the major issue is we have an opioid tolerant patient who's using illicit opioids every day, clearly in significant pain, and it's unethical to not treat their pain. But for the physician and provider, we feel like, my gosh, well, what am I even supposed to do? The beauty of emergency medicine is we are a dynamic, flexible specialty, and one of the major initiatives that's coming up, it's already here, but it should be expanding, is regional anesthesia. We are masters of procedures, and we are masters of learning new skills to address the public health crises that come our way. So the regional anesthesia is a piece that I believe a lot of residencies are trying to incorporate because of how important it is, how effective it is. And we want to have, an army of physicians and providers coming out having this technique. So in somebody where opioids are questionable, we've exhausted our alternatives, this is when regional anesthesia shines. Shines in many cases, but this is one of them. So for a bimal, we would be looking at doing a popliteal block. And you do have to understand how to do this block. This is not something that you just watch a YouTube video and do. But if you're savvy with ultrasound and you're savvy with a needle and ultrasound, this is something that should be an evolution for you in your practice. And the popliteal block is an easy block. You're basically putting the probe in the back of the knee. The popliteal nerve is kind of a chubby structure there. It's easy to see. There's not a ton of significant high-risk vasculature around it. And you would use something like ropivacaine, which is long-acting, local anesthetic, and you can put a few cc's around. And what that does is that provides pain relief, bringing the pain to zero, which is impossible to do any other way. And this patient is splinted on crutches anyway. So you will knock out their motor function, but they're not walking. So then you break crisis. And I have to say that's an important thing to think about in emergency medicine. We're not going to stop everybody's pain. But if we can break crisis, we might be able to maintain tolerable pain management outside of the ED. And a wonderful way to break crisis is to get rid of the pain completely by blocking. That I understand is a technique and a skill that many of us may not be comfortable with. So as we kind of go through our toolbox, another option is a favorite of all ED folks is ketamine. So ketamine, being an NMDA receptor antagonist, is excellent when you can't rely on the mu receptor. We should have it in our EDs, and a way to use it without getting into the controversy of monitoring or no monitoring, for these subdissociative analgesic doses, when we're trying to do infusions, we can use it intranasal. So getting it in your ED for intranasal use is a really nice way to give it quickly, easily, and absolutely without any monitoring. The one tricky thing is the concentration. So ketamine, we would give intranasal. The max is 50 milligrams per dose. And the concentration matters because you can't give more than 1 milliliter in the nostril. So we need to have a concentration in which we can get around 50 milligrams for an adult in 1 cc, or at least break it up. So you could have 2 cc's, 25 maybe in one nostril, 25 milligrams in the other. But this is beautiful. We don't need a line. We've given our alternatives and we're trying to break crisis. And then when either you have none of those things, then we have to rely on opioids. And this is where we all get a little hung up, because this patient sees opioids every day. They have immense risk for overdose, but we have to be ethical in our care, and we have to have a conversation with the patient, but provide them something. So I would lean on morphine oral. There is emerging data that suggests oxycodone is extremely likable, extremely desirable, and therefore potentially more addictive because of what happens in the brain. It deposits in the nucleus accumbens and ventral tegmental area, our addiction centers. It's very lipophilic. So morphine has been around forever and it works. It may have more itching. We may have to be careful in renal patients, but it works and it's just less likable, meaning I may not want to keep using it, but it's certainly effective. The opioid naive dose is around between 7.5 and 15. The oral tablets come in 15. So I like to, if I'm giving in an opiate naive patient, start around 7.5, use our alternatives. In an opioid tolerant patient, we're starting at 30 at minimum. This patient's seeing fentanyl, and we know that the fentanyl potencies are very, very high in the milligrams. So starting at 30 and reevaluating, giving another 30. This may be someone who spends a little extra time with you, but if you can get the pain just tolerable, you could send them home with a couple tablets of morphine, PO, and close follow-up. We have to remember to try to engage any peer support if we have that in our emergency departments. Very important to try to engage, health engagement in general for this patient, navigator services if you have them. It's an opportunity to really engage with someone who has a very high mortality, and they're in front of us. So we really have to capitalize on that.
Alexis, help me think about one part of that, which is, we increasingly provide team-based care in our emergency departments. We're working alongside our nursing colleagues as well as pharmacists often. And so I think, one of the things we often hear is when you've got the opioid tolerant patient who you're treating for acute pain, those dose numbers are a lot higher than what people are used to prescribing or used to even administering in this ED setting, whether it be sort of the fear of what bad thing could happen after discharge, or even could this person have an adverse effect while they're in the ED. How do you navigate that? Like, what's the script to do that? How do you navigate it if there's reticence from the pharmacist or the nurse in that ED?
I believe that we are the team leaders. We need all of our team members, but we are certainly leading the team as we're making these complicated clinical decisions. I find it's important to get ahead of that question. So we know that if you're ordering 30, 45, 60 of morphine oral, someone's going to turn around and be like, what is LaPietra doing? So I like to get ahead of it and educate. It's our job to really educate and help our team understand why we're doing things and build champions and build educated champions who are going to advocate for the next patient. So when I order this, I know. So as soon as the order is placed, I go find the nurse. I sometimes will call pharmacy. We have a clinical pharmacist, so I can tap her shoulder if she's there. And I will say, so bed 3, the gentleman who has that ankle fracture, he does have opioid use disorder, but he's in so much pain. So you're going to see that morphine there. And I just want to give you a little bit background as to why. So, his brain, he sees opioids every single day, but he has acute pain. It's our job to address that. But we have to remember that because his brain sees opioids every day, if we give him something that we would give someone who's opiate naive, it's completely ineffective. We really shouldn't bother. We're not doing anything for him. So we have to go higher, and it feels a little bit, scary, but he's here with us. We're going to keep an eye on him. And just the pharmacology, the common sense, the neurobiology, this is why we do the higher dose.
I really appreciated that perspective, and particularly, we put the case to say that the patient was not interested in treatment, but you really did say, bring it back that still try, right? If you've got a peer that's available, this might be an opportunity, even if the patient says initially that they're not interested.
Yeah.
So our second case.
I just wanted to add, I think it's really easy, and we all know this, it's really easy to brush this patient off. Because if they don't want to engage in treatment, why are we bothering to try and force treatment on them? But we know that there is immense shame, immense stigma, and there's a lot of trauma in this population. And when they come to the hospital, we are not generally very nice. Historically, we have not been very nice. So if we're able to just simply engage in an empathetic conversation, even if it doesn't result in treatment for their use disorder, changing the trajectory for them and showing them that they can come into a healthcare setting and receive empathetic care, that is a win in of itself. And I also forgot to mention naloxone. So naloxone kit for this patient, we know they're not going to fill the script, but if that's what you have, please give the script or let them know where they can go and get it. But all of those are harm reduction strategies. And we hope that the next time that he comes around, we've planted some seeds.
Great. Well, I'd like to shift gears a little bit for our next case. And so this is also a patient with opioid use disorder, but this is a patient who's in recovery on buprenorphine or Suboxone. They're currently taking 16 milligrams of buprenorphine per day, and they've been very stable and doing really well on that dose. But they present to the ED with right upper quadrant pain. You've got the usual differential diagnosis suspects. It could be cholecystitis, could be pancreatitis. You're grabbing your ultrasound probe. You might do a CT and labs. But she's really uncomfortable. What do you do in that situation where these receptors are occupied by the buprenorphine?
Yeah, so good case. This patient, we want to start, like all of the other patients, with remembering we do need a foundation of non-opioid alternatives. Just because someone is opioid tolerant does not mean they will not benefit from the alternatives. We want to give them the benefit of giving some alternatives, multimodal approach, synergistic effect of the medication. So this patient sounds like we're probably having them be NPO. We are going to place a line. We are going to give 15 of ketorolac. If you have intravenous acetaminophen, I mean, that's probably another podcast, but if you have it available and are able to use it, go ahead and give that. If the patient is able to take a few tabs oral, we'd love to get that acetaminophen in there alongside the NSAID. And then if there's a component of nausea, droperidol is a great option. Again, I know some of this stuff is not as readily available, but droperidol has some analgesic properties, and it's of course very, very good for nausea. So we're sneaking in that foundation of analgesics, non-opioid. You're going to give that a chance. You're going to give that 30, 45 minutes. Another thing I think that we don't think of, the data is not awesome, but it is not harmful, is magnesium. Intravenous magnesium, 1 or 2 grams. There is some data to suggest for abdominal pain, it can be helpful. And it's not a high risk med. So adding that on, and I know it sounds like we're throwing the kitchen sink, but we are, because not only are we trying to avoid opioids in general, we also have a patient whose brain has a lot of high affinity opioid in it, which is bupe. So bupe has a very high affinity. It doesn't want to come off the receptor. After that, I would say we have our ketamine. So all these folks, ketamine is a low-hanging fruit. So we've done Toradol, acetaminophen, droperidol, magnesium, ketamine. None of that's working. We are going to opioids. So all of these cases are going to end up with opioids if all of these alternatives are not going to work. But this is the same conversation we just had. We cannot give 4 milligrams of IV morphine to someone whose brain sees opioids, whether or not it's fentanyl or bupe. So for this, same conversation about nursing in your team. This patient is opioid tolerant. This patient has high affinity partial agonist opioids in their brain. We're going to give hydromorphone 2. We're going to give potentially morphine 12. If patient can take oral, we're doing morphine oral. And the trick is going to be to come back to reevaluate. So we're going to give a high dose, high affinity opioid like hydromorphone. 2 may not be enough, but upon reevaluation, if they are awake and breathing and still in pain, they deserve another dose. So the concern is what, we're going to make them apneic? Extremely unlikely. We know that bupe is protective against overdose because it is so high affinity to that receptor. So now we really have to give enough opioid to find the unoccupied mu receptor in the brain. So if we have a bunch of receptors saturated with bupe, we have few to work with to get a full agonist on. So we might have to go quite high. And these doses make people nervous. But every time you dose, it's with a clinical evaluation to justify the patient is not hypoxic, they are not sedated, and they require and deserve adequate pain management. So it's really titration, titration, titration.
Alexis, help me understand, or help explain, I think, to our listeners one part about this, which is, unfortunately, I think there's often a very simplistic view of being in treatment or not in treatment. And part of this is related to, you'll take somebody and sort of initial teachings that they have to be pretty severe withdrawal in order to start treatment for somebody. And so I think one of the fears I hear from clinicians is that in this patient example, they're afraid that they're going to do harm by giving that hydromorphone or giving that opioid to a patient who's already on agonist therapy. Like, are they, and I think the things I've heard are like, are they going to sort of re-trigger their addiction? Are they going to make the treatment not work as well? Is this going to be a setback because the patient comes in and says, oh, I'm doing great. I've been in treatment for 4 months right now. And so I think there's this real fear that you're going to, really worsen someone's addiction or substance use disorder because of the treatment of acute pain. What do you say to those folks?
Totally valid concern. Totally valid. And cheers for thinking of it. Cheers for patient-centered, individualized care plans. Everyone is different, and this is a unique patient who is certainly challenging. The decision to give full agonist opioids in someone who is in treatment should be a conversation with the patient. and there needs to be a risk benefit. Everything we do needs to be a risk benefit. So there is a risk for sure of some euphoria, for triggering some desire to potentially reach for the substance that they are trying to avoid. So we have to have that frank conversation. If it's someone, if it's a single dose, we have the patient monitored, we talk with them. The discharging of patients who are in treatment and we're giving them full agonists, that is a beefier conversation, in that you want to make sure that that person's village or that person's team is aware, especially the person who's prescribing their bupe. But, we're going down this road, which is a little slippery, and we want to make sure Jen has some support. If she's speaking to a peer or a sponsor, or has a spouse or a sister or a friend or a neighbor, who's your village? Because maybe we need to lean on our village a little bit during this time where you're not feeling good and we have to use some high risk medications for you. But if the pain is intolerable and you're suffering, that's not good either. That's a trigger also. That's a slippery slope in of itself. And that's why all these cases are complicated. And all these cases have everybody between a rock and a hard place. But really, it's a conversation. It's patient-centered. It's transparency. And it's understanding risk benefit.
So the next case I wanted to ask is, increasingly adding wrenches to the cases to make them a little more complicated. So now let's say we've got a 32-year-old male who has opioid use disorder as well, but this patient's on Sublocade, which he last received around 2 weeks ago. He has a very bad motor vehicle accident. He's unrestrained. He has 3 rib fractures, hemopneumothorax. He needs tube thoracostomy. So talk us through this, and maybe just some people may see patients with Sublocade and some people may not. And so if you can just talk us through what that is a little bit too, might be helpful.
Sure. So Sublocade is a long-acting buprenorphine. We equate it to around between 16 and 24 milligrams of buprenorphine per day, but you only get the injection once a month. This is wonderful for people who struggle on, am I going to take my bupe today? Or you can imagine when we all have bad days where we just kind of say like, I don't want to take it today. Maybe I want to do something else. So this allows a blanket of buprenorphine all in the brain for a month. And it takes the daily dosing out of it. And we know for many other medications, this is the easiest thing to do. We know for birth control, other mental health things, just a monthly injection is easy for anybody. There's not as much compliance involved. So folks who are stable on bupe for just a very short time can get Sublocade injection from the physician office, and then that's it. They don't have to make that decision to take it every day. So we do know that it's buprenorphine in your brain. So it's between 16 and 24 milligrams of buprenorphine in your brain. He got it 2 weeks ago, so it's certainly there now. And this is another case, the kitchen sink. We're throwing the kitchen sink. Low-hanging fruit, easy, best treatment, if you can pull it off, is an erector spinae or serratus anterior plane block. Why? Because anytime we block someone, the outcome is beautiful. Zero pain, and we're never going to get there with anything else. The only way we get to zero pain is intubated or with local anesthetic usually. So putting an erector spinae block in will address the severe rib pain, fantastic for rib fracture. And then of course, you can then place your chest tube easily. So erector spinae block, serratus anterior plane block, they are easy, ultrasound, needle, you're done. This is a ketamine patient for sure. You most likely have a line in. The hemodynamics may not be great. You might be a little bit worried. There might be some hypotension, which we accept, of course, in trauma, but the ketamine, we don't see a lot of change in, of course, in vital signs. So giving kind of a 0.1 or 0.2 milligram per kilogram slow infusion, and then we can keep them on a continuous infusion, 0.1 milligram per kilogram per hour. So this is nice. We can give them some ketamine, and then we can keep them on the ketamine. And then lastly, it's opioids. So lastly, it is high affinity opioids, which are going to be fentanyl or hydromorphone. So we want opioids that are going to bind tight to those receptors. We know that bupe is on and locked in. We also have to remember dosing. So you're going to call out to your team, patient is on Sublocade, they're opioid tolerant, we're going high with our fentanyl or hydromorphone, we're going to give 200 mics IV of fentanyl every 5 to 10 minutes, reevaluating to see if we're effective, or we'll do hydromorphone 2 milligrams every 15 to 20, letting the team know, shouting it out in the trauma bay like we do, and making sure that we are actually getting good pain relief. So titration, titration, titration.
So let's modify this last case a little bit and say, what if a patient is on Vivitrol or long-acting naltrexone or even methadone? How does that modify your management?
Great question. Methadone is easier, so we're going to start there. Methadone is like any other full agonist opioid. Someone is on 80 of methadone a day, their brain sees 80 of methadone a day. We have to realize the doses are higher. We use our alternatives. We lean on ketamine. If it's something we can block, we block it. So really, when you look at it, bird's eye view, it's all the same. The mu receptors are occupied. And no longer does oxycodone 5 or morphine 7.5 is not going to cut it. So we just have to remember there are fewer receptors that require higher dose opioids. And we want to dose appropriately, but titrate, lean on our team to nudge us and make sure we have, at least tolerable pain control. So methadone is like illicit fentanyl, is like Sublocade. It's something on the receptor that the brain sees every day. Vivitrol and naltrexone are, I'd say, the most challenging out of any of this. So whether or not it's alcohol use disorder or opioid use disorder, your mu receptors are blocked. Naltrexone daily is different because, of course, the efficacy wanes over the course of the day, but Vivitrol is that 30-day injectable, and that's locked in for 30 days. So you have almost no mu receptors to work with. You really need to, this, of course, again, I know that there's such a spectrum of practice, and that some folks in rural critical access areas where they don't have a big team, other places that are academic and have more team, but we want to use everything possible because really we are not going to get where we want to go with opioids. So I'd say, if you're going to ACEP or you're going to conferences, you develop some relationships maybe with folks who see these patients or find some good websites. We really need like a phone a friend, but we need to know that it's alternatives, it's blocks, it's maybe PCAs. And this is a patient that probably needs to go to the ICU if they are staying. Maybe needs to go to the ICU, dexmedetomidine infusion, or a PCA, but if it's a real significant case where they are going to have a ton of pain, it is going to be scary for everyone, and it is going to be difficult for everyone. So they need a high level of care, and they need a lot of multimodal analgesia.
Alexis, that's great. Thank you. It's been amazing sort of hearing you think about these cases. As I think about it and we reflect on sort of what we've seen in the eQual network, and through our work over the last 4 or 5 years now, it's been that, the patients who come to the emergency department have not changed. Almost everybody does come with some form of a pain syndrome. I think like 9 out of the top 10 reasons for an ED visit will remain abdominal pain, chest pain, headache, injuries, and things that require us to be able to really provide effective analgesia. It's on this background where our data shows that, emergency physicians have done a wonderful job in one aspect of opioid stewardship, which is getting the prescriptions down and sort of being thoughtful about administering opioids, reducing adverse events in the emergency department setting. It's the second part, though, that you bring to the conversation today that I think is where we're headed, which is getting really facile with these alternatives so that we can help meet the patient where they're at, treat them for exactly what they came to the ED with, but doing it in a smarter way with a bigger armamentarium, a wider portfolio. So it was awesome hearing about that from you today. We give every one of the guests on Quality a chance to get the last word. And so if there's any one final thing you want to share with the people listening today, what do you want to make sure they hear?
The cases that make you squirrely are the cases you need to dig into. These are squirrely cases, and I hope we see more Sublocade. I hope we see more methadone. I hope we see more Vivitrol. I hope we see more OUD. Every chance we get to engage with the population is a win. So I'd say dig deep, find your grit, and challenge yourself by learning a new technique. You are going to only make your life easier in a situation that's probably not changing in the near future. So get down, remember why you went into emergency medicine. You love procedures, you love hands-on stuff. Go learn some regional. It'll reinvigorate you. It will allow you to treat patients such a higher level of care, and you're going to feel good.
I love it. The harder, the better.
Yes, amen.
Yes. Well, thank you for joining us. We'll hope to have you back on a future episode in the series. And thank you, everybody, for tuning in today. Yet another great podcast in our Equal Substance Use Disorder series.
Thanks.